Almost every resident is handed an abnormal liver panel in the first week. And almost every resident starts by asking how high. That is the second question. The first question is what pattern? Because the pattern tells you which organ compartment is injured, and it narrows the differential before a single extra test is sent. Today we build that framework. The tests themselves, the patterns they make, the R value that formalizes it, and the 2 published algorithms for cholestatic and infiltrative disease. Let's begin. Meet our patient. A 54-year-old man with no symptoms at all. He had blood drawn for a life insurance policy. His alanine aminotransferase came back 888. His aspartate aminotransferase at 62. His alkaline phosphatase at 140. And his bilirubin is normal at 0.9. He feels completely well. He wants to know if something is wrong with his liver. By the end of this video, you will be able to answer him systematically, rather than by ordering everything. Here is the plan. First, the individual tests and what each one actually measures. Second, the 2 tests that genuinely reflect hepatic function. Third, the patterns those tests make together. Fourth, the R value which turns the pattern into a number. Fifth, the approach by magnitude. Mild elevation acute, mild elevation chronic, and severe elevation above 1000. And finally, the 2 algorithms. One for the cholestatic pattern, and one for the infiltrative pattern. Start with the language because it causes real confusion. We say liver function tests, but most of the panel does not measure function at all. Aminotransferases, alkaline phosphatase, and bilirubin all mark injury or obstructed bile flow. They tell you something is happening to the liver. They do not tell you whether the liver still works. Only 2 tests measure synthetic function, albumin and the prothrombin time. When someone asks how bad is the liver failure, it is those 2 you look at. The aminotransferases are intracellular enzymes. They are released when cells are injured or inflamed, and their membranes become leaky. Alanine aminotransferase is concentrated in hepatocytes, so it is much more specific to the liver. Aspartate aminotransferase is everywhere. Heart, skeletal muscle, kidney, brain, and blood cells. So a raised aspartate aminotransferase is not automatically a liver problem. And remember what the height means. It reflects the rate of ongoing injury, not how much function has been lost. Here is a reflex worth building. Most hepatocellular injury raises both enzymes with alanine aminotransferase usually higher. So when the aspartate aminotransferase is the higher of the 2, stop and think. That pattern points towards musculoskeletal injury or myocardial infarction. And it points towards alcohol-associated liver disease where the ratio is classically at least 2 to 1. If muscle is plausible, check a creatine kinase before you send a hepatitis panel. Alkaline phosphatase is bound to the hepatic canalicular membrane, the bile-facing surface of the hepatocyte. So it rises with biliary obstruction, with intrahepatic cholestasis, and with infiltration of the liver. But it is also made in bone, intestine, kidney, and placenta. So an isolated raised alkaline phosphatase with everything else normal is not a liver result until you prove it. Confirm the hepatic source with a gamma-glutamyl-transferase, a 5' nucleotidase, or fractionation of the isoenzymes. Follow the molecule. Bilirubin is a product of heme metabolism. It starts out unconjugated and water-insoluble, so it travels to the liver bound to albumin. That is the indirect fraction. Inside the hepatocyte, it is conjugated, which makes it water-soluble. That is the direct fraction. And then it is excreted into bile. Now the logic falls out. A problem before or at conjugation raises the indirect fraction. A problem after conjugation raises the direct fraction. And because direct bilirubin is water-soluble, it appears in the urine. So split the fractions. An indirect or unconjugated hyperbilirubinemia means hemolysis, or an enzymatic disorder of conjugation. Gilbert syndrome is the common benign one. Crigler-Najjar is the rare severe one. And because unconjugated bilirubin is not water-soluble, there is no bilirubin in the urine. A direct or conjugated hyperbilirubinemia means cholestasis of any cause, or one of the rare excretion disorders like Dubin-Johnson and Roeder. And direct bilirubin does appear in the urine. One number to remember. Jaundice generally becomes visible when the total bilirubin exceeds about 2.5 milligrams per deciliter. And where you look matters. The sclera and the mucosa under the tongue show it earliest. Skin color, lighting, and your own expectations all make skin a less reliable place to look. So when you suspect jaundice, look at the eyes and lift the tongue. Now the 2 genuine function tests. Albumin reflects hepatic protein synthesis, and it has a half-life of roughly 15 to 18 days. That long half-life is exactly what makes it useful. A low albumin implies the problem has been going on for weeks. Prothrombin time depends on the liver synthesizing clotting factors, all of them except factor 8. And because several of those factors have very short half-lives, the prothrombin time can rise within hours of significant liver dysfunction. Reading them together is more informative than either alone. A normal albumin with a rising prothrombin time suggests an acute process. The liver has not been failing long enough to deplete the albumin pool. That is the picture in acute liver failure, and the prothrombin time is your early warning. A low albumin together with a raised prothrombin time suggests chronic synthetic failure over weeks or longer. That is the picture in cirrhosis, and you should be looking for the other stigmata. Now we put the tests together. 4 patterns account for almost every abnormal panel you will see: hepatocellular, cholestatic, infiltrative, and non-hepatic. Recognizing the shape narrows the differential before you order anything else. Here is the hepatocellular half of the pattern table. In general, hepatocellular injury raises both aminotransferases markedly, with the alkaline phosphatase only mildly up. Within that, viral hepatitis and metabolic dysfunction-associated steatotic liver disease usually show alanine aminotransferase higher than aspartate aminotransferase. Alcohol-associated hepatitis shows the reverse, with a ratio of at least 2:1. Ischemic hepatitis raises everything dramatically. And in fulminant Wilson disease, the ratio of alkaline phosphatase to total bilirubin is under 4. And here is the rest of the table. The cholestatic pattern raises alkaline phosphatase and direct bilirubin markedly, with aminotransferases only mildly up. The infiltrative pattern raises alkaline phosphatase, with near-normal aminotransferases and near-normal bilirubin. That combination is the fingerprint of something occupying space in the liver. Then the non-hepatic rows. Skeletal muscle injury raises aspartate aminotransferase far above alanine aminotransferase early. Bone disease raises alkaline phosphatase with a normal gamma-glutamyl transferase. And hemolysis raises indirect bilirubin alone. The R value formalizes the pattern. Take the alanine aminotransferase and divide it by its own upper limit of normal. Take the alkaline phosphatase and divide it by its own upper limit of normal. Then divide the first by the second. An R above 5 means hepatocellular injury. An R below 2 means cholestatic injury. And between 2 and 5 is a mixed picture. Normalizing each to its own reference range is what makes the ratio meaningful across different laboratories. Work it through with me. His alanine aminotransferase is 88, against an upper limit around 40 for a man. So roughly 2.2 times the upper limit. His alkaline phosphatase is 140, against an upper limit around 120. So roughly 1.2 times the upper limit. 2.2 divided by 1.2 is about 1.8. That sits at the cholestatic end of mixed. But look again at the absolute numbers. The alanine aminotransferase is the clearly abnormal one, and it is under 15 times the upper limit. This is a mild chronic hepatocellular picture. Once you have the pattern, magnitude, and time course, drive the workup. There are 3 practical buckets: mild to moderate elevation, that is acute, the same magnitude but chronic, and severe elevation above 1,000. Each has its own differential and its own first tests. For an acute rise under 15 times the upper limit of normal, start with the history and examination, and assess the risk from alcohol, drugs, and toxins. In alcohol, the aspartate to alanine aminotransferase ratio runs above 2:1. Get abdominal imaging to exclude cirrhosis, hepatic congestion, or biliary obstruction, especially if the picture is mixed. Think about other infections: tick-borne illnesses, cytomegalovirus, Epstein-Barr virus, and COVID-19. And remember that an acute presentation can simply be the first time a chronic disease has been noticed. For a chronic mild to moderate elevation, work through 4 groups. Viral. Send hepatitis B surface antigen, surface and core antibodies, hepatitis C antibody with RNA, and an IgM hepatitis A. Metabolic. Metabolic dysfunction-associated steatotic liver disease is the commonest cause worldwide, so check body mass index. A lipid panel, a hemoglobin A1C, and a liver ultrasound. Then, the other causes of cirrhosis. Iron studies, ceruloplasmin and urine copper, and an alpha-1 antitrypsin level. And finally, autoimmune and endocrine causes. 2 causes are forgotten more than any others. Thyroid disease. Both hypothyroidism and hyperthyroidism are associated with abnormal liver tests, so send a thyroid-stimulating hormone. And coeliac disease, which is a genuinely under-recognized cause of persistent transaminitis. Also remember that alpha-1 antitrypsin deficiency can cause liver disease with no lung involvement at all. If the whole non-invasive workup comes back negative, liver biopsy is the next step. And repeat the panel first. Some elevations simply go away. Now the other end of the scale. An aminotransferase above 1,000 narrows the differential dramatically, and an elevation above 5,000 narrows it further still. This is a short list, and you should know it cold. Above 1,000, the list is short. Ischemia, hypotension, Shock, severe heart failure, or Budd-Chiari syndrome. Those often go above 50 times the upper limit. Drugs and toxins. Acetaminophen above everything else. Then isoniazid, amiodarone, nitrofurantoin, immune checkpoint inhibitors, and over-the-counter and herbal products. Acute viral hepatitis A through E and reactivation of hepatitis B. And then the others. Acute autoimmune hepatitis, acute biliary obstruction, and rhabdomyolysis, or heat stroke. Here is a discriminating ratio worth carrying. In ischemic hepatitis, the lactate dehydrogenase rises along with the aminotransferases because the same ischemic insult damages many tissues. So the ratio of alanine aminotransferase to lactate dehydrogenase runs below 1.5. With toxins and viruses, the aminotransferase rises out of proportion, so the ratio runs above 1.5. And note one important negative. Alcohol alone does not produce elevations of this magnitude. If you see them, look for another cause. Now the two published algorithms. The first one starts when the alkaline phosphatase and bilirubin dominate the panel. The whole algorithm turns on a single question that an ultrasound answers. The cholestatic algorithm begins when alkaline phosphatase and bilirubin dominate the panel with the aminotransferases only mildly raised. The first test is a right upper quadrant ultrasound. And the entire algorithm turns on one question. Are the bile ducts dilated? Dilated ducts mean mechanical obstruction somewhere downstream. Non-dilated ducts mean the problem is inside the hepatocyte or in the small intrahepatic ducts. Two completely different workups follow from that one answer. 3 destinations. If the ducts are not dilated and the alkaline phosphatase is only mildly up, think biliary epithelial damage, hepatitis with a raised alanine aminotransferase, or cirrhosis with a raised prothrombin time and low albumin. Workup hepatitis A and E, Epstein-Barr and cytomegalovirus. If the ducts are not dilated but the alkaline phosphatase is markedly up, think intrahepatic cholestasis. Medications, parenteral nutrition, sepsis, postoperative state, or primary biliary cholangitis. Review the medications, stop the parenteral nutrition, and check an antimitochondrial antibody. When the ducts are dilated, you are looking for a mechanical cause. A stone, a tumor, or a stricture. Choledocholithiasis, cholangiocarcinoma, pancreatic cancer, and sclerosing cholangitis. The next test is magnetic resonance cholangiopancreatography, computed tomography, or endoscopic retrograde cholangiopancreatography, depending on how likely a stone is, and whether you intend to treat in the same session. And if the non-dilated workup comes back negative, the algorithm sends you to cholangiography and liver biopsy. The second algorithm handles a distinctive and easily missed pattern. A raised alkaline phosphatase with near-normal bilirubin and near-normal aminotransferases. Something is occupying space in the liver. 4 categories: malignancy, hepatocellular carcinoma, metastatic disease, and lymphoma, granulomatous disease, tuberculosis, sarcoidosis, and histoplasmosis, abscess, amoebic or bacterial, and a residual group, medications, amyloidosis, and idiopathic. What unites them is that they occupy space and compress small bile ducts, which raises alkaline phosphatase without producing enough hepatocyte injury to raise the aminotransferases, or enough obstruction to raise bilirubin. The workup runs in order. First, confirm the alkaline phosphatase is coming from the hepatobiliary system with a gamma-glutamyl transferase. If it is raised, imaging is usually the first step. A right upper quadrant ultrasound or a computed tomography scan of the abdomen. If those are negative, consider cholangiography to look for biliary pathology. Send a serum protein electrophoresis to exclude amyloidosis. And be prepared for liver biopsy. Infiltrative disease is frequently a histological diagnosis, and imaging alone often does not settle it. Drugs cause abnormal liver tests constantly, and the pattern the drug produces is reasonably characteristic. Learning a few in each column is more useful than memorizing the whole list. Here are the key rows grouped by pattern. The hepatocellular column. Acetaminophen, isoniazid and pyrazinamide, statins and fibrates, amiodarone and methotrexate, allopurinol, immune checkpoint inhibitors, and valproic acid. The cholestatic column. Angiotensin-converting enzyme inhibitors, anabolic steroids, oral contraceptives and estrogens, cephalosporins and macrolides, and chlorpromazine. And the mixed column. Amoxicillin, clavulanate above all, carbamazepine and phenytoin, sulfonamides, and tricyclics. For any drug you suspect, check the liver tox database. Where this goes wrong: calling them liver function tests and forgetting that only 2 measure function. Assuming a raised aspartate aminotransferase is hepatic without ever checking a creatine kinase. Working up an isolated alkaline phosphatase without confirming with a gamma-glutamyl transferase that it is hepatic at all. Failing to fractionate the bilirubin. Ordering every serology at once instead of establishing the pattern first. Reading a normal ultrasound as excluding early obstruction. And blaming alcohol for an elevation above 5,000. Back to our patient. His aminotransferases are under 15 times the upper limit, and alanine aminotransferase exceeds aspartate aminotransferase, which argues against alcohol. His albumin and prothrombin time are normal, so synthetic function is intact. His bilirubin is normal, so this is not cholestatic. We sent the chronic panel. Viral serologies negative. Iron studies, ceruloplasmin and alpha-1 antitrypsin, normal. Autoimmune, thyroid and coeliac studies negative. And his ultrasound showed increased echogenicity. With a body mass index of 32, this is steatotic liver disease. 5 things to carry with you. 1. Only albumin and the prothrombin time measure hepatic function. Everything else marks injury. 2. Establish the pattern before you order anything. Hepatocellular, cholestatic, infiltrative, or non-hepatic. 3. The R value formalizes it. Above 5 is hepatocellular. Below 2 is cholestatic. 4. The entire cholestatic algorithm turns on one question. Are the ducts dilated on ultrasound? 5. Above 1,000, the differential is short, and you should know it cold. These are the sources behind today's teaching. The American College of Gastroenterology Guideline on Evaluation of Abnormal Liver Chemistries. The British Society of Gastroenterology Guidelines published in Gut. The Stat Pearls Review of Liver Function Tests. The American College of Gastroenterology Guideline on Drug-Induced Liver Injury. And the LiverTox database maintained by the National Institute of Diabetes and Digestive and Kidney Diseases. Thank you for watching. Verify everything against your own institutional protocols.